Now, you mentioned hepatitis B, hepatitis C. How do you approach that? Is it a distinct subgroup of people who are HIV positive?
Well, a lot of people with HIV also have hepatitis B or C co-infection. Right. And the drug that we would prefer to use in individuals with hepatitis B is tenofovir.
Okay.
Tenofovir not only treats HIV, but it also treats hepatitis B. And the TAF formulation of tenofovir has recently been FDA approved to treat hepatitis B as well. So those individuals with hepatitis B, we definitely want to give them a tenofovir inclusive regimen. Usually, you know, we're as Eric said, we're thinking about a nucleoside combination, which is either going to be TAF FTC or abacavir lamivudine. That's going to be the nucleoside component. So if somebody's got hepatitis B co-infection, we're going to give them a tenofovir inclusive regimen.
Okay. Now what about hepatitis C?
Hepatitis C, again, you know, the great thing about the integrase inhibitors is they don't have a lot of drug-drug interactions. So,
at least 2 of the 3.
You know, right. Yeah. So we can use dolutegravir or raltegravir. Mm-hmm. We could use abacavir lamivudine. There's few drug interactions with the TAF formulation.
Very few.
Right.
So for the most part, these same regimens are pretty safe and effective. Yeah. Occasionally there's a drug-drug interaction that, you know, an astute HIV, Hep C provider will be aware of. But for the most part, hepatitis C doesn't influence our treatment decision anymore.
Right.
Now,
it certainly did, but not so much.
What about comorbidities, patients with bone disease, kidney disease?
Well, that's where it gets a little sticky, right? Where you get people that are newly diagnosed, but they're older, they have diabetes perhaps, they have renal dysfunction, then you really have to be careful, and that definitely influences your choices. I mean, and you know, you have women that you know have multiple pregnancies, and you know may be really at risk for osteoporosis. We know that tenofovir, especially the TDF form, lowers bone density. The TAF form appears not to do that. So you want to think very carefully about the comorbidities. You know, and there is the drug-drug interaction issue. There, and in people that are on some of the more complicated diabetes regimens, you know, maybe there's things you need to consider. But in general, again, as Ian said about Hep C, what we're choosing now is really so tolerable. It really, you know, and the interactions are few, and the effect, unless you have really frank renal failure, then you're kind of a little bit more stuck.
One thing is we face the issue with comorbidities more commonly in the people who have been on therapy for years and years and years, rather than newly diagnosed patients. All of us have this panel of patients now who are aging with us, and you know they've been on HIV treatments, sometimes very toxic HIV treatments for 5, 10, 15 years. And so they're the ones we sort of struggle on the comorbidities more than the newly diagnosed patients. One of the companies tried to do a study of people with newly diagnosed HIV and renal disease, and it's actually very hard to do because there aren't that many people who have renal disease.
We talk about it a lot
at the get-go.
But it's not that common.